announce that our item number 7, which was the presentation regarding the Oregon program, will have to be rescheduled due to the date change and time change. We were unable to move forward with that one today. So we'll go ahead and do roll call. So I'm Marla McDade Williams. I currently chair the committee, and I am here. Terry Kearns.
Present.
Mark McBride.
Present.
Scott Killebrew.
Present.
Senator Wynn. Lieutenant Diane Goldstein.
Present.
Assemblyman Max Carter.
Present.
Assemblywoman Danielle Gallant.
Here.
Jonathan Dalton.
Present.
Mujib Shad. Burton Tabak.
Here.
And Dustin Hines. I believe he said he was unable to make it today. Catherine Cotter.
Present.
Joshua Garber.
Present.
John Alseguera. And if any other members joined after I went through roll call, please let me know. I'll try to watch the screen, but it's down to one screen today, so I'm just punting here. So this is the time.
You didn't call
go
my
ahead.
name, Kimberly Jarovieski.
Okay, yeah, so you'll be up on the agenda next. So this was just the members of the committee that we did the roll
Okay.
call for.
No worries.
Okay, so on to agenda item number 3, public comment. To provide public comment telephonically, dial 1-775-321-6111. When prompted to provide the conference ID, enter 407-099-411#. If providing public comment during the Teams meeting, unmute your microphone prior to speaking. Persons making comment will be asked to begin by stating their name for the record and to spell their last name. Is there anyone wishing to give public comment at this time? Okay, I don't hear anyone. So our first presenter, Dr. Jane, are you on? And I'm sorry, and number 4 is for possible action. It's the approval of the April 12th meeting minutes. I was not able to get those done in time for this meeting. So we'll move on to agenda item 5, which is the presentation identifying the benefits of the therapeutic use of entheogens and identification of available resources, supporting the benefits of their use. Shaylee Jane, psychiatrist.
I'm present.
Okay, are you prepared to share your slides, or would you like me to do that for you?
If you could do that, that would be lovely.
Okay, so give me a second. Sab. Close. Go.
I think it just.
Can you see it?
Oh, there it is.
Okay.
Yeah.
Go ahead.
All right. Thank you, everyone, for having me, letting me come speak to this committee. My name is Shaylee Jane, last name Jain. I'm a local psychiatrist in private practice in Las Vegas with a long-standing interest in psychedelic medicine. I had also extensive training in different modalities of psychotherapy. And the interest of doing depth work led me to offer ketamine-assisted psychotherapy for the last several years, which, although not a classic psychedelic, but has given me a working understanding of working with non-ordinary states of consciousness in people with post-traumatic stress disorder and treatment-resistant depression. And what I'd like to focus in my presentation today is a psychiatrist's perspective and considerations regarding the therapeutic use of psychedelics, primarily for mental health, as that's my area of work. I wanted to just start with just talking briefly about the disease burden that we are facing. About 13 million Americans suffer from PTSD in any given year, and 8.9 million adults are estimated to have medication-treated MDD, major depressive disorder, in a 12-month period, 30% of whom have treatment-resistant depression. It is not surprising that if you look at surveys regarding psychedelic use, they reveal that the primary motivation for experimenting with psychedelics for people is health-related. People are afraid to tell their physicians that they're contemplating using psychedelics or have used psychedelics to get some relief. And in my experience, talking to people, that most people that end up technically breaking the law by seeking psychedelic treatment underground would say they would much prefer to be a patient than an outlaw, but they were also willing to do whatever it took to survive. The challenge then is when desperate, vulnerable people seek treatment underground or at times overseas. Again, many settings can provide excellent care, but there can be settings that are risky, that lack the level of safety and support that people truly deserve, right? And they run the risk of being preyed upon by the unscrupulous or hurt by the incompetent. So as I wanted to sort of move to highlight a few resources for the committee to reference at will. At the reference section, I included links to the psychedelic drug development tracker that's offered by Psychedelic Alpha, which tracks different companies that have phase 3, phase 2, and phase 1 trials underway. And then the second link is of the interdisciplinary psychedelic bibliography, which in 2022, there were like 183 noteworthy publications that you can sort of access on with this link. And in 2023, the number is over 500 in this interdisciplinary annotated bibliography. Yes, this is a growing field that is insurmountably complex and needs to keep maturing and refining as it investigates risks and benefits and possible harms that can come from such treatments. I've also provided the link to the Nevada Psychiatric Association's online continuing medical education library, which has the 2024 pre-conference lectures on psychedelics available. And the NPA conference manager, Katie Regal, will be emailing Ms. Williams with the complimentary access to the lectures for the committee to utilize as they wish. I know many of you were present for the pre-conference, but rather than summarizing the current state of science and clinical data that is available, I wanted to provide these links to the committee for use. As far as you know, the challenge with these Schedule 1 drugs is that it's extremely difficult to get funding for this kind of research. The regulatory system around this has been very strict. And so, you know, this field is growing and maturing as we sort of go along. But I wanted to sort of spend the bulk of my presentation today, talking about sort of some clinical considerations from a practicing clinician who has some experience working with non-ordinary states of consciousness that can inform, in my hope, the committee as it sort of deliberates on the possibility of therapeutic use. I've been a psychotherapist, psychiatrist for the last 25 years, and I would say with like deep humility that nothing prepared me enough to work with non-ordinary states of consciousness. Sorry. I believe that, in my opinion, that this is not a field for early career therapists. It should be, people should have years of doing psychotherapy without adding a supercharged layer of working with these visionary substances and in non-ordinary states of consciousness, and that people need additional training to work with psychedelic medicine. Ideally, this treatment is provided in a collaborative, trauma-informed care model that has a treatment team that includes psychiatric clinicians and therapists and possibly other medical professionals in a biopsychosocial paradigm of treatment. That would be ideal if that is possible. I know that Utah is proposing a pilot program that that offers that will be offering therapeutic use of psilocybin and MDMA as behavioral health treatments, and at University of Utah and the Intermountain Health System. What I wanted to highlight are some considerations with respect to additionally with like medical and psychiatric clearance. I think looking at some of the information from the Colorado guidelines that their committee has come up with, I think there's some aspects of there's some conversation about the recipient having, getting some medical or psychiatric clearance, because many people with post-traumatic stress disorder or treatment-resistant depression, they have tried multiple treatments and they may be on complex current treatment regimen that includes medications. This needs to, they may also need to be screened for the possibility of the risk for psychotic illnesses or bipolar disorder or seizure disorder and other things that really inform clinicians in the team to whether this person is a good candidate for this sort of treatment. I think we want to minimize like a cottage industry of clearance professionals, so it would be helpful to give consideration whether recipients have a relationship with existing professionals that are doing this sort of collaborative care clearance, and do the medical and psychiatric clinicians have an accurate understanding of psychedelics, and how do we really inform people and educate and give them support and education so that this becomes a more safe use and practice. I think it's my opinion that that ongoing consultation groups for clinical facilitators and treatment teams is very helpful and important. That is above and beyond just continuing education requirements to maybe maintain facilitator licenses if clinicians do pursue something, a licensure for psychedelic facilitation, because you want to minimize this sort of pervasive self-deception that exists in all clinical settings regarding boundaries. I think we think that that boundaries, that we handle boundaries well as clinicians and other people may not, but we're all susceptible to blind spots, and we need checks and balances in place so that we reduce the issue of relational boundary violations and misconduct. I think additionally, having some consideration about who do patients undergoing treatment report to, right? To the facilitator's licensing board? Is that who they report to? If so, how do you educate and provide support to professional boards who may or may not have a good understanding of the field of psychedelic medicine for both the protection of the recipients or patients, but also for clinicians who are interested in providing such treatment, to offer them support as well. I think patient advocacy groups focused on psychedelics can be extremely helpful, and should be encouraged. In addition, I think guidelines with respect to preparation and ongoing informed consent. I think informed consent in psychedelic work is an ongoing process. It's always happening, that you're always getting consent as treatment is unfolding, about safety issues, about having realistic expectations, about set and setting and patient selection, and who do you provide this treatment to, and dosage and indications, but also things that I don't think we talk enough about, which are post-psychedelic difficulties or derealization or spiritual emergencies or really serious adverse effects that can potentially also happen. Post-treatment support in the form of integration with the clinical team, especially if a person is experiencing serious adverse effects or suicidality, etc., but also use of community integration circles. I think we underutilize community integration circles, and I think being able to create avenues where there is psychiatric and psychological and medical support for these post-psychedelic difficulties, and adverse effects, in addition to like spiritual emergencies. I think some form of REMS or a registry to gather some observational data about outcomes, but also incidents of post-psychedelic difficulties, like derealization, spiritual emergencies, and serious adverse effects would be very helpful. And creating ethics guidelines for facilitators, establishing some guidelines for standard of practice, disciplinary procedures, but also harm reduction. And so in the interest of time, I wanted to sort of keep some of what I had to offer brief, because I wanted to see if people had any questions. But I'm happy to, I think lastly, for members of this committee and interested parties, both for and against these visionary medicines, I highly recommend reading Johanna Kempner's new book that came out actually earlier this month, which is called Psychedelic Outlaws. And she's an associate professor of sociology at Rutgers, whose research focuses on gaps in knowledge. And she wanted to know why science and medicine fail to produce research on topics that by any measure are important to understand. So she herself started having headaches at the age of 5, and she chronicles the journey of the Cluster Busters Citizen Science Network, who, desperate for an effective treatment for cluster headaches, take it upon themselves to find a possible solution using low-dose psychedelics. And if one of the stories that really stood out to me is, in the book, is of Andrew Clemenshaw. And it's an example of this desperation that drives people to sort of these outlawed medicines. Andrew began experiencing cluster headaches in middle school. When his mom took him to the doctor, they dismissed his pain as stress related, right? That maybe he was just being bullied, was the gist of the medical appraisal. And that cluster headaches are no joke. They feel like searing hot wrought iron jamming into your eyes. And they said the intensity is worse than a gunshot wound or unmedicated labor, according to people who've experienced both. And it's so bad that nearly 70% of people suffering experience suicidal thoughts during attack cycles. And the fact that it takes an average of 5 years to get a diagnosis, again, these all add to the complexity and desperation that people feel. And Andrew had no reference point for his pain, so he just sat in class and tried to stay calm when experiencing this kind of agony that would make most adults scream for mercy. And when he was 17, his mom discovered cluster busters and learned about psychedelic medicine, and he credits it for saving his life. And he's not exaggerating, because in the book he talks about, he likes to say it was psychedelics or suicide. And I think that this book sort of highlights how maddeningly difficult it is for treatment protocols to move and be engaged with the scientific community and with physicians who are willing to listen and consider studying these forms of treatment. And so I will end with just sort of a hope that that people, that care and consideration, that we look at both the life-saving aspects of what these treatments have to offer, but also finding ways to do it responsibly and ethically and sustainably. So with that, I will end.
Thank you, Dr. Jane. Jonathan Dalton.
Thank you. Yeah, I just had a question for Shaylee on regarding say psychedelic assisted therapy. What is your knowledge of the safety profiles of psychedelics when they're used as part of psychedelic assisted therapy when proper dosage, set, and setting are utilized?
Well, my knowledge is based on what I've I did my training with MAPS, so I'm familiar with some of the protocols that they were engaged with. I work above ground, and so my experience has only been with ketamine-assisted psychotherapy. But I'm familiar with many of the research protocols that have been available, and so I think. So I'm not sure if I'm answering that correctly. I think that with careful consideration of set and setting and careful patient selection, this is not treatment that not everybody is a good candidate for this kind of treatment. And then the consideration of whether people have existing medications on board, tapering them off, managing their comorbid illnesses while you then do some preparation and treatment and post psychedelic support, which is really essential, because essentially the treatment, psychedelics are facilitating a change in a change in sort of neuroplasticity, where you actually can have, so the psychotherapy or psychological support that you offer people is as essential as the medicine experience itself. Not to say that people don't, I think people often have this experience of like, oh, I used psychedelics in college and I had profound experiences, but people who may describe that may not have disabling PTSD and treatment-resistant depression. They are vulnerable patient population that require support and care and consideration. So, yes, please.
Thank you. Any additional questions? Scott, you're muted. Yeah, I don't know.
It's on top, the mic to unmute.
Okay, can you hear me now?
Yes.
Can you hear me now? Can you hear me now? So your expertise is solely psychological, right? Your expertise that you're presenting, it has nothing to do with physical reaction to the, to the treatment.
Well, I'm a psychiatrist by training and a psychotherapist, so I, from a perspective that there is there is both physical and psychological challenges that people experience. I did MAPS training, and so monitoring people's blood pressure throughout treatment. Again, this is MAPS training was not experiential for clinicians yet. It was primarily looking and reviewing case material and looking at their protocol in depth. So I have experience with both physical and psychological effects of using ketamine as the.
I guess my direct question is like,
Yes.
Alcohol has negative physical effects on the body. Like in relation to alcohol, that's kind of where I'm going with that question.
Yeah. Well, I'm happy to send some articles. There's a body of literature. Matthew Johnson from Johns Hopkins, he's no longer at Johns Hopkins. He has a paper that I'm happy to send about psilocybin and its safety profile that looks at abuse potential. It looks at physical aspects from a perspective of, from an aspect of people who, I think majority of difficulties that people experience with psychedelics are psychological. There is the incidence of physical difficulties are more brief during treatment or during the active administration of treatment, but their majority of what is concerning to people are sort of psychological effects or aspects of derealization or persistent perceptual abnormalities, and those sort of things can happen. They're rare, but they can happen. Tabak just put the.
It's not going to give you cirrhosis, right?
No, it's not going to give you cirrhosis. It's not known for. That's again, and I think that article that that looks at the safety profile. These are safe. They're physically safe medicines, but they have to be used appropriately. There is, if you review the NPA pre-conference, there was Kellen Thomas, who's a PsyD. He talked a lot about drug-drug interactions between psychiatric medicines and psychedelics, and there is some need to investigate cardiovascular effects, which really the place that's been concerning, where there's sort of some beginning to be some information coming out, is in the microdosing world, where people are using low dose, ultra low dose microdoses of psychedelics, but over a period of time, right? Every third day. And so there is some consideration that there may be some cardiovascular effects when you use it that way. Now, all research-based treatment for depression, for treatment-resistant depression, PTSD were using macro doses. They're using big doses in very limited portions, right? Like the MDMA protocol has 3 treatments of MDMA. We're talking about psilocybin, Compass. They've had single dose treatments, but they've had like two treatments, right? So we're not talking about this, there is some, we're not talking about this as like a chronic use sort of treatment. As I said, there is some cardiovascular concerns with microdosing, and I think that is getting investigated more and more, but that's not part of.
So what would be a scale between a macro dose, macro dose, and a micro dose? What would be the difference? How much?
So like for psilocybin, a macro dose would be like, well, I think in the studies it was like, so like if you look, a macro dose would be, a micro dose is like, they use the jeweler's scale, and that they use like 0.04, sort of microgram. I mean, like this is like, the proportion is like 1,000-fold.
Basically,
like
you don't even feel it. You don't
you
even
don't
feel it.
you're not supposed
Okay.
to. Like a microdose is, you should not feel a single effect. Like you shouldn't feel any psychedelic effects of the medicine. That's a microdose. A macro dose is, you're not really going anywhere for a period of time, because you are internally, this is an experience that is taking you somewhere. Sort of.
Thank you.
Of course.
Kate.
Thank you, Dr. Jane. We really appreciate this. Very helpful. So my question is, if you might be able to share with us about the Dr. David Nutt harm scale, and piggybacking on Scott's question about safety. And my understanding is that, for instance, alcohol is 12 times safer than psilocybin, and I know there's a wealth of information there, so I'd be curious to hear your expert opinion on that.
I think that's maybe a complex. It probably has it's a complex answer, because I think safety is all dependent on how you use it. Alcohol kills multiple people, like it destroys lives, and there are a lot of people who can use it recreationally and never be affected adversely by it, right? I think it's how you use any substance used without consideration is dangerous and toxic, right? So again, safety, I think safety, we're talking about physical safety, psychological safety, but safety with respect to set and setting and how treatment is delivered. And I think there's all sorts of things so I think safety needs to be looked at in many different ways. I think that adequate preparation, a deep understanding of a person that is being administered this treatment can help mitigate, and settings that really truly offer support and have sort of considerations for people's safety is necessary. So I don't, and then the other part is like boundary violations and, relational harm that can happen in these settings. These are powerful substances. People are in a vulnerable state of mind, and the people who are offering treatment have the potential for, if they're, of a power differential that happens in treatment that really has to be acknowledged and honored and considered with this treatment to be effective.
Are there any other questions?
Just to
Well,
get
thank
it
you,
on the
Doc.
record, Dr. Tabak put several papers in the chat, including the David Nutt harm scale. I just want to make sure that was noted for the record.
Thank you.
Yep.
Well, thank you, Dr. Jane. We appreciate your time today. I do want to note that Senator Rochelle Wynn has joined us, as well as John Oseguera, who completes the membership for the committee. So we're happy to have a full committee now. So the next agenda item, we are going to skip number 6 for now. But if Kimberly Juravsky is ready, she's going to present on issues relating to insurance coverage for entheogens.
Hi, everybody. I'm Kimberly Juravsky. First, I'd like to start by just telling you a little bit about my story and how I got involved in this world. I am a veteran of the United States Air Force. I was injured on active duty during a war games exercise. And from my injury, I developed something called complex regional pain syndrome. For those of you who don't know what that is basically a disease where your brain and your body are not talking to each other properly. And it's caused by an injury and causes you to feel like your body is on fire. So basically, I was initially injured in my arm and had surgery, woke up from surgery and felt like my arm someone had lit matches on my arm and it was completely on fire. Unfortunately, I then had a secondary accident, and within minutes, it actually spread into my leg. Due to this, I was unable to work. I was unable to do my job in the Air Force. I should say that I was a nurse midwife and a nurse practitioner in the Air Force, so my job was in the medical field. And I got early retirement due to my injuries. I also developed PTSD and severe depression from this and was extremely suicidal. I was completely bedridden, couldn't move, couldn't put a shoe on, couldn't put a sock on, couldn't wear clothes, and was in terrible pain when a friend of mine sent me an article about ketamine being used for complex regional pain syndrome. Unfortunately, at that time, that was back in 2011, almost nobody was doing ketamine back then. If they were doing it, it was thousands upon thousands of dollars, something I was not able to afford. That friend 2 years later then sent me another article about a research study that was being done at the Hospital for Special Surgery in Manhattan with ketamine for complex regional pain syndrome. And she said, hey, you got to apply for this study. So I immediately applied for it. And 6 months later, they called me and said, hey, you still interested in this study? And I'm like 100%. I went in for multiple interviews and finally got accepted into the research study. I was admitted to the hospital for 5 days and was lucky enough to get the real ketamine, not the placebo, and came out of the hospital with a 50% reduction in my pain, was no longer suicidal. My depression was better and my PTSD was better. I completed that study after a year and it was amazing. It literally saved my life because I no longer wanted to die. I was able to do things with my family again. I could get off the couch. Now, I don't want to say it was a cure. You know, my pain wasn't completely gone and I had to keep going back for infusions in order to keep the pain down. But I definitely no longer wanted to die. And that was like huge for me and for my family because I had small children. And then after the study was completed, well, I'm like, well, what am I going to do now? So I start looking for a place to continue doing ketamine. And unfortunately, nobody was taking insurance for it. So I started a Facebook group that has now over 14,000 ketamine patients from around the world in it. And the one common theme is lack of access because people can't afford ketamine infusions. Infusions cost an average for mental health doses about $500 a dose. And for pain doses, anywhere from $1,000 to $2,500 for one dose of ketamine. It's extremely expensive. For the most part, most insurance companies will not pay for ketamine. They're claiming it's off-label, it's experimental, we don't need to pay for this, we don't want to pay for this. So due to that, about 5 years ago, I decided that I need to fight to change this and started an organization called the Ketamine Task Force. We've been fighting now for 5 years. Unfortunately, we've not had a lot of success. We've not had a lot of traction. We started out by going to the AMA and saying, hey, can we make some new CPT codes to cover this? And they laughed at us. They basically like, who the heck do you think you are? So then we decided to go to Medicare and we were working with Medicare. We presented a bunch of research to them and we were trying to get them to pass a national coverage determination because if Medicare passes a national coverage determination, then most other private insurance companies will kind of follow. And unfortunately, they felt that the research wasn't strong enough, even though we presented them with over 60 research studies. So at that point, we kind of regrouped and we started looking at what's called a local coverage determination. And we said, okay, let's do this on a state by state basis. We also started working with somebody from the FDA to try to figure out if we can get this actually on label. Because if it's on label, then the insurance companies can no longer call it an experimental drug. Unfortunately, there's been a lot of hurdles with that. One of the biggest being, in order to get a drug sponsored by the FDA to be put on label, you have to have a drug manufacturer who puts in the application for that. And the application costs about $1 million. And then it costs money to keep continuing to make sure that the drug stays on label. It's like a whole very difficult process. But we're not going to let that stop us because we've literally had thousands of patients come to us asking for help, saying they need this medicine. You know, they've tried every other antidepressant out there, and unfortunately, nothing has worked for them. We've unfortunately had a number of suicides in our groups, and it's been very tough. It's been very hard, but we're not going to let that stop us. We are going to keep fighting, and you know, we definitely want to get this done, no matter how it happens. And we feel possibly maybe Nevada could be the first ones to pass a law saying that insurance companies have to cover this because, you know, it's very safe. Ketamine has been around since 1962 or 1963 was when it was first created, and it began to be used in hospitals around the world. And in 1970, the FDA put it on label for anesthesia. And it's actually one of the safest anesthetic drugs. It is used in pediatrics more than in adults because it does not repress or suppress the respiratory system. So it's a very, very safe drug to use, has very few long-lasting side effects when used appropriately. Now, of course, I know Scott was talking about alcohol and alcohol abuse before and how it can have effects on the liver and things like that. Well, I want to say this. Every single drug out there has potential side effects. Watch any TV commercial about a drug, and you are going to see a laundry list of side effects. This drug may cause death. This drug may cause an infection in the brain. You see it on every single drug. But you have to know how to use the drug safely and appropriately. So one of the things that has been seen in people that abuse ketamine is bladder issues. So that's something we know about. It is a side effect, but there are ways to prevent that side effect from happening. So basically, your depression patients should not be taking ketamine every single day. They should be spacing it out because, yes, ketamine is harsh on the bladder, and we know it affects what's called the GAG layer of the bladder, which are the same cells that are affected by something called interstitial cystitis, which is an autoimmune type disease that affects the bladder. But when a ketamine patient is treated once a month, it's very safe. They don't have bladder side effects. They don't have issues, and those cells we are seen to regenerate. So every single drug out there has potential side effects, but that's why we need good studies. That's why we need it to be FDA approved and on label with indications for proper usage, indications for dosage. Again, dosing. We've had, I can't think of any deaths from ketamine, but then you get a story like Matthew Perry, where they're blaming it on ketamine. Matthew Perry did not die from a ketamine overdose. He died from drowning. Ketamine should never, ever be used near an open body of water. High-dose ketamine should not be used in an unsupervised setting. So there needs to be guidelines. There needs to be rules for safety, just like so my daughter takes a drug called Stelara. She has Crohn's disease. I'm not going to give her 5 vials of Stelara. That's not how it's prescribed to her. She's prescribed 1 dose every 90 days. That's the safest way to give it. That's the way that Janssen & Janssen Pharmaceutical, who did all the studies on it, found that it could be given safely and used for Crohn's disease to keep it in remission. So same thing with ketamine. There needs to be more studies. So our ketamine task force has been working to put together a longitudinal study to show the best way and the best protocols for ketamine. And we plan to bring that to the FDA, hopefully in 3 years from now. But meanwhile, patients can't wait. And we need to start getting states to put mandates for insurance coverage. And we need to start getting this covered by insurance because every single day, so about There's approximately 1 suicide every 12 minutes. So think about that for a second. Once, while we were in this meeting, a bunch of people already killed themselves. So if we had ways to stop that, whether it's ketamine, whether it's psilocybin, whether it's MDMA, you could stop it in your tracks by allowing access to these medicines. And our veterans, it used to be that they said there was 22 suicides a day for veterans. Well, now the new numbers came out. It's actually 44. I mean, that's unbelievable. These are people who served our country honorably and committed their lives to helping us. Why aren't we helping them? Why are they being left behind when we said no man should be left behind? So we need to pass this, and we need to make sure that there is access to these medicines. Anyone have any questions?
So now, in some of the materials you provided, there was a document from Blue Cross Blue Shield of Vermont, ketamine corporate medical policy. Did you want to
Yes.
talk a little bit about that?
Yes. So Blue Cross Blue Shield of Massachusetts and Vermont actually decided that, yes, ketamine is a worthwhile medication and it is helping people. And they wrote into their policy that there should be coverage for ketamine infusions. And they are so far the only private insurance that is guaranteeing coverage. Also, Kaiser Permanente has provided also very limited coverage for some of their patients. So that's also a big move forward as well. So I think several places in California are now covering it. I think the senator had a question.
Senator Nguyen.
Thank you. I have a question on the coverage. Was it covered, like, did those jurisdictions, did those insurance companies just decide to do that on their own? Were they mandated, like, in statute? Did it start by coverage by Medicaid? Do you know kind of the intricacies of how those particular organizations decided to cover it?
I don't know exactly. I did hear that there was some push from some of their clients and patients who helped to get it on with them, but it was not mandated. No.
And then I guess if I can follow up, when it comes to, and I don't know if you know this or not information, but I know right now it's like people are privately paying for ketamine therapy, and it can be very expensive. But it's not like ketamine hasn't been around for a very long time. So is it like, is there generic ketamine? Like, is it
Yes.
something that should cost this much? Why does it cost this much still at this point? Like, does anyone have any of that information?
Yeah, so ketamine costs about $20 a dose. But of course, when you're getting in a doctor's office, you're getting an IV infusion, so there's the doctor's expenses that you're paying for, but it definitely has a higher price tag probably than it should. I think that probably doctors could bring some of their costs down, but again, they want to make a living as well, which I get, nothing's free in medicine, unfortunately. But the main cost is the administration, unfortunately. So, you need the staffing, you need your medical supplies, you need your IV tubing, your IV bags, you're paying your rent, you're paying your medical malpractice. There are a lot of expenses involved in administration of any IV drug. I mean, like, look at these cancer centers, how much they charge, even for the generic.
I get that, and I value the medical professionals. So when you talk about the insurance covering this medication, are they covering the administration of the dosage? Because it's not like you just go to the pharmacy and pick up your vials of ketamine there, right?
Right. So they're not. So when Blue Cross Blue Shield put that into their insurance, they're talking about covering the whole procedure, not just the medicine itself. There are some practices have gotten Medicare to cover infusions, But Medicare has a code for generic infusion of a medication, and it reimburses about $60 for an hour's worth of a medication. So again, it's a very low reimbursement, and the average practice, unfortunately, can't keep their doors open for that. So there is one practice in Florida, for example, and people actually travel from around the country, pain patients, to see him, because what he does is he infuses 10 patients at once so that he brings his costs down. He has 2 nurses. He requires a family member to be in the room with the patient. So God forbid a nurse is with another patient and someone's having an emergency, they can run out and get that nurse and drag them over. So he's tried to make it as cheap or inexpensive as possible, so that he can take that Medicare reimbursement. But Medicare's reimbursing like $60 to maximum, I think, $75 per hour of medication administration. And again, that's they're only paying for, it's a very generic code. So they're not paying for the medication. They're not paying for most of the IV stuff. You know, they're paying very minimal.
And then you had another handout on Medicaid case studies. Did you want to just briefly describe that?
I don't remember which one that was.
Improvement of mental health symptoms in response to ketamine therapy in Medicaid eligible patients. Or is that just for our information?
Yeah, that was more for your information. That
Okay.
was a study that was done by a clinic in Colorado who actually has gotten Medicaid to pay for IM, intramuscular ketamine. Intramuscular can be a slightly less expensive route of administration, just because it requires less like supplies like IV tubing. It requires less continuous monitoring because you're not having like a chance for an IV to accidentally suddenly speed up. You know, the medicine is given all at once. So it is a slightly less expensive, and there are some clinics that are using that route of administration. They're charging about $300 a dose versus the $500 price tag. But Medicaid in Colorado is reimbursing for that. I do not know how much they're reimbursing though.
Thank you, Josh Garber.
Thank you very much. Just from a law enforcement perspective, you know, the 3 drugs that you have been talking about, so ketamine, MDMA, and psilocybin, we have an extremely large music festival that happens every year here, and it just recently got over. Those were the 3 most drugs that we recovered from an abused standpoint for the users using at these large music festivals. So I think what happens is when we start, you know, legalizing or making it available to everybody, then, you know, the user at these festivals, you know, it gets away from the public too as well. So I'd like to, you know, just take that into consideration that when we start legalizing these drugs, that because they are Schedule I drugs, so that's what we could call it, that when we have large events that use psychedelic medicines, we're starting to see a huge increase in these drugs, making it popular. And I think from a professional point of view, that is due to the fentanyl issues that we're facing too as well in the country. So we are seeing a ton of psychedelic drugs being abused here in the Vegas Valley as well.
Also, ketamine is a Schedule 3, not a Schedule 1, just so you know. It does have.
No, I
medical
understand
uses.
it. I said it was a scheduled drug.
Yeah, no, of course.
Yeah, I don't
Could you
really want to get into
the
it.
3 that you said, Josh? I didn't hear you. I'm sorry. The 3 drugs.
So the 3 drugs that we as a section, so here in narcotics section for our agency with our federal partners too as well, the 3 drugs that we recovered the most, and again, large music festivals with a couple 100,000 people, so there's only so much that we could do, was this year alone was the first time in 15 years that psilocybin was the most recovered drug. Second was MDMA, and third was ketamine.
And again, I don't want to get into a debate and a discussion about the legality or illegality of anything. But Dr. Tabak, do you have something that's constructive and follow up?
All I was just doing was simply making a statement for the record.
Extending gratitude to both Dr. Jane from earlier and to Kimberly for your input to the committee. It's very well received. I do want to just indicate and underscore that ketamine is quite dissimilar from the classic psychedelics. Being a dissociative, it can occasion a psychedelic-like experience. And from the studies, what we know is that ketamine requires, as Kimberly noted, maintenance and often multiple rounds of treatment, whereas psilocybin, the benefits that can potentially be garnered can be elicited through as little as one dose. And so I think the benefit here could be to acknowledge that ketamine has been, because its scheduled status, there is a clear, well-defined pathway to patients getting access, and there's already a protocol in place for patients for treatment, and it can serve as a model for insurance and reimbursement and billing. So just to provide some scope here, I as a medical professional feel that the potential benefits of psilocybin are superior and more efficacious and more safe to that of ketamine. And I guess a really important point to discuss would be, if and when these entheogens are decriminalized or approved in a medical context, how do we institute the right setting, the right context, the right personnel to administer the medicine, to work with the integration and the psychotherapy component, and also, of course, to go through insurance. So with that, I think that the conversation can really open up to looking at ketamine as a model for a medicine that's already in place in the medical system. The other thing is, ketamine is much shorter in duration, where you can have patients come in for a couple hours, where psilocybin and MDMA have a much longer therapeutic window. And so it's very practical to bill and see more patients in a day when utilizing ketamine. So these are all the different elements and nuances that I just want to make sure are captured for the record. Thank you.
Thank you. Diane.
A couple things is, as this discussion unfolds, and Dr. Tabak is right about model policies, I think we need to be looking at model policies, not just here in Nevada, but across the country. I don't know if people are aware that the governor of Arizona signed a bill that basically will allow the coverage of MDMA once it's rescheduled, which I think is up and coming, for workman's compensation. So our discussion on this issue aren't outliers. It's happening as we speak. And I think the more that we can ground ourselves in policy to provide therapeutic protocols and safe access and minimize the risk to public safety, the better we will be. And I won't talk about arrests at this point, because I know we're going to be getting a briefing on that later.
Thank you. Any additional questions or comments for Mr. Robreski? Go ahead, Jonathan Dalton.
Yeah, I will do some homework after this, because I am familiar with a couple of ketamine clinics, one in Las Vegas and one in Reno, that do have Spravato covered under certain circumstances by healthcare. And I think that would be fantastic to be able to take that model, as Dr. Tabak and Kimberly were saying, take that model if Spravato is covered, and be able to, replicate that with other psychedelics. So more to follow on that, but I'll see what I can come up with and bring it forward the next meeting.
Thank you. Dr. Jane, I would like to move on if we can. So I noticed that there were some comments put in the chat. We do have discussion later on in the agenda about potential subjects for future meetings. So if we could kind of hold things and move through, I would like to go, if you all don't mind, to our next presentation by Lieutenant Ailey Burnett on the laws that prohibit the use of psychedelic medicines.
Hello, everybody. I appreciate the chance to come and talk to the board. So thank you so much for having me. Again, my name is Ailey Burnett. I'm currently the lieutenant over LVMPD narcotics. Just to give you a little bit of background about my experience and training, I've been with Metro for almost 24 years. During that 24 years, I've done almost 10 years in narcotics alone as a detective, as well as a lieutenant as a supervisor. I've been through many different vast areas of the department, such as the gang unit, Office of the Sheriff, Special Investigations, Intel, again, narcotics, vice. I've done a little bit of everything. So, as well as being a patrol officer. And every time I promote, you have to go back to the streets doing calls for service in patrol. Again, when in talking today, this does give me a little bit of concern. I will definitely say that. And I appreciate that you have individuals on here who have experience and able to speak about how psilocybin and other psychedelics have definitely helped them in their condition. We do not have any of the victims here who have been victims of the same drugs. And so therefore I love the opportunity to be their voice. Being in law enforcement, again, for almost 24 years, I've seen a lot of things. Unfortunately, I have seen how shrooms have adversely affected the community and seriously hurt others. The effect that it has on the brain is, in my opinion, very dangerous and has the potential for horrific acts. I can go into detail about, we have here, this was many years ago in Las Vegas. A woman was walking her baby, her infant child, in a stroller. Man came out with an axe and smashed her baby's head open with the axe and also attacked her. Of course, the baby died. We have another instance in California. We have a UFC fighter. They were doing shrooms, shroom tea. He attacked his roommate, gouging out his eyes, his tongue, splitting open his chest and ripping out his heart, and he took a bite out of it. A man here locally was just sentenced to 25 years in prison for killing his roommate while he was high on shrooms. We also have another recent one that was made national news of the airline pilot who was on an airplane full of people while he was high on shrooms and attempted to take the airplane down, almost killing everybody. These are a lot of different instances where these people have experienced violent outbursts. One incident, in my opinion, is too much. This may really help some individuals, and I'm not saying it doesn't. I'm not a doctor. I can only talk to you about my experience, what I've seen in the field, and this is on-hand experience. When you talk about how many people does this affect or does it help, what is the percentage? We're talking about a Schedule I controlled substance. Sometimes it feels like we're putting the cart before the horse. That if this is a Schedule I and we're saying it's a medicine, then let's go through the proper channels of having it rescheduled. There's been a lot of talk about ketamine. Ketamine is a Schedule III. It is a medication that has been approved for medicinal use. Psilocybin Schedule I is not. We have other psychedelics, other hallucinogens that are already available. I don't know what the research has been done on those to see if those also have the same effects. Have we looked in also of a pharmaceutical company looking into recreating a synthetic form of psilocybin to see if that helps? But if this really truly is medicine, and there's documented proof that this is medicine and it helps individuals with certain conditions, then why not go through the proper channels and have it rescheduled through the DEA? I think we all agree that this is not something to take lightly. We have a responsibility here as public servants and lawmakers to make sure that we protect and serve the entire community, not just a small percentage. So we should look at, if it's medicine, it should be presented to the DEA and have it rescheduled, and it should be under a doctor's care, a doctor's administration and a doctor's care. That is one of the issues. So if everybody's talking about right now that it's medicine and how do we do this to provide to certain individuals with certain conditions, and we talk about microdosing, macrodosing, and trying to get that right, then it should be under a professional with a medical license to be able to administer and to be able to watch and care for an individual and see what happens. The only way that's going to be able to happen is if it is a schedule 2, 3, 4, or 5, and or at least, or it could be not scheduled, obviously, but for a doctor to prescribe and then to be under a doctor's care to review. In which case, again, it would have to be rescheduled. So if we're talking about not rescheduling it, there's no way to just reschedule it in the state of Nevada and have a doctor's care because they all have the DEA numbers and they won't be able to do it. It has to be through the DEA. If we're talking about a clinician, again, it's going to be very difficult. It should be very highly scrutinized. It should be highly watched because it has a high potential for abuse, high potential. And we really have to think about these positive effects that help, I'm assuming, a very small percentage of the human population. Does it outweigh the deleterious effects of the drug when we're talking about affecting the entire community? Again, in law enforcement, we are the ones that have to deal with the deleterious effects. We are the ones that have to handle individuals who have abused this substance, who are then going into excited delirium states, who are then attacking others. And then we are the ones that have to go to those scenes and watch these horrific acts where people are brutally murdered, attacked, and then we have to deal with the individual and then live with that ourselves. So I ask that this be taken very seriously, that we have this responsibility to not put the cart before the horse, that we do it right. Again, we have other psychoactive drugs, we have hallucinogens. I'm going to bring it up like marijuana. It is a hallucinogen, is a psychoactive drug. I don't know that is already legal. Obviously, it's still Schedule 1 federally, so a doctor still can't prescribe it. But have there been studies done on, does that have an effect? Does that have a help? Obviously, the federal government right now is looking at rescheduling that particular drug. So it just seems sometimes we go super fast, and we've already seen the deleterious effects of doing that too quickly, because we have seen it here in law enforcement. If anybody wants to know more about that, I can also talk about it. But again, we don't have the voices here of the victims who have been horrifically, their lives horrifically changed from psychedelics, from individuals losing it, attacking people and killing others. One is too many. Again, I plead that we do this right, that if we want clinical trials, or if this is definitely medicine that has helped people, let's take that data, let's take that information, let's take it to the DEA, and let's have it properly scheduled so it can be under a doctor's care and it can be prescribed by a doctor. I'll open up for questions.
Diane?
Hi, Lieutenant Burnett. First of all, thank you very much for your service. I'm a retired police lieutenant from Southern California and currently the executive director of Law Enforcement Action Partnership. I'm going to just ask a couple things because I don't disagree with you, but some of the what we're describing is outliers, right? I want to know a couple things. I pulled the Substance Use and Criminality in Nevada report that goes back to 2016 to 2023. In 2023, it states there were 3,129 drug-related arrests in the state of Nevada. Do we know how many of those are for all psychedelics? And do we know how many of those can be broken down to MDMA, ketamine, etc.? And only because the Daisy Festival is such a big event, is how do we show that's the majority of arrests or the minority of arrests as a start? Do we even have any data to show the significance of the psychedelic problem in the state?
So I'm sorry, maybe make sure I have your question correct. You're asking exactly how many psychedelic arrests we have that are associated with psilocybin. Is that your question?
No. Yeah, well, my question is, number of drug-related arrests in the state of Nevada was 3,129. Out of those, how many are for psychedelics? And out of that small portion for psychedelics, can you break down the data points on top of that?
So I don't have that here for now, but if you want to send that question via email, we can definitely try and pull the numbers for you in regards to that. So when you're talking about specific arrests, you have to remember this is the entire department. So if you're talking about Olive Clark County, I don't know if that's just going to include LV and PD, North Las Vegas and Henderson. We also have the DEA and FBI as well, but we can try and get those numbers for you. I have basically what we do as a section, and how we break it down and seizures such as that. But that question for right now, if you want to give that through an email, we can try and pull some numbers if you need that specifically.
Yeah, that would be great. And also specifically, I'd like to know how much psychedelics are being seized. So I was at a judiciary hearing in January, and I heard an amount that was based in grams. And so, 453 grams roughly equals 1 pound. So I'm trying to wrap my head around how much of a problem is this, because, I sit there and I think about the leadership the state of Nevada has shown relative to the issue of cannabis, right? This is the same thing in some senses. Is the FDA has declared psilocybin a breakthrough therapy. MDMA will probably have a decision on whether it's going to be or rescheduled down from 1 to 3. And there's a lot of controversy relative to the issue of how the DEA even schedules drugs. And I'll leave it to some of the scientists here to have that discussion. And so I just think there's a lot of complexities here. I also believe that prohibition itself actually fuels a lot of the harms that are caused on this issue. We do have to take it seriously. Everyone understands that there's been victims in the past. I worked gangs, I worked narcotics, I ran a team. I'm acutely aware of the damage that drugs can do in our community, and we need to reduce the harms of that as much as possible. But prohibition actually sometimes promotes harms and not necessarily reduces them. Thank you very much. I really appreciate it.
No, thank you so much. I could tell you just for right now, the numbers that we have just for this year, this is from January until June of current June right now. So just this year, in just my section alone in narcotics with LVPD, we've seized 164.45 pounds of psilocybin. That is for the first 6 months of 2024. And that is just for the narcotics section alone. That does not include what other sections and other parts of this department have seized, nor does it include the other OJ departments that we have here. But that'll just give you a little snippet of what it is.
Dr. Tabak.
Yes, want to echo the gratitude for your service. And I would be remiss if I didn't clarify a couple elements that the latest science has identified. Something, just to be clear, is that psychedelics do not lead to dependence and are not abused when presented in a clinical setting. And the Schedule I designation is perceived among the medical community who are well versed in this field as a political designation, not a medical one, because not only do these drugs not lead to dependence, but they also do have medical value for treating entities like depression, PTSD, anxiety, and addiction, rather than causing it. It can help ameliorate addiction. The other thing that's really crucial to underscore here is that psychedelics are not like any other drug, in that they are very dependent on the set and the setting and the context that they are given. And so the aim of this working group is to really bring to light and articulate and guide the appropriate boundaries in which these medicines are given in a therapeutic setting. And screening patients is paramount. So we know that psychedelics are not for everyone. And if there is a predisposition for schizophrenia or psychotic illness, then that can absolutely tip someone off into the deep end where you can have a risk of harm. And so it's important to frame the discussion that by creating a pathway for people who are the right candidates to receive these medicines in a controlled clinical context, there's actually, I would argue, the opportunity to reduce harm, reduce risk, reduce adverse reactions to the community.
I don't mean to interrupt, but again, we're not here to debate back and forth the benefits or not benefits. Everybody has the opportunity to present their perspective, and we have the next discussion item where we're going to go through other items that we want to present for the agenda to make the cases that you all want to make. So I don't want to get into back and forth, debates about all of this, but did you have a specific question for Lieutenant Burnett?
Okay, I see. So this whole format is just set up for questions, not discussion?
Not at this point, correct.
Okay, then I'll leave my comment there. Thank you for the clarification.
Thank you. Scott? You're muted still.
So you are, from a police perspective, because I did a little time there too. From a police perspective, you are saying that that psilocybin is a drug that enhances the anger and the potential for you to be angry and violent and attack people. It's not like, and marijuana is like, people say, yeah, I go to the bar, I've seen a lot of guys, fight when they're drunk, but very few guys fight when they're on weed, right? So you're saying that psilocybin is a drug that makes you more violent. Is that what you're saying?
I'm saying it definitely has the potential. So it's a psychoactive hallucinogen. So what it does do, and it has in the past, is cause people to have hallucinations and act violently towards others. I'm not saying every single person who consumes it, and if it, like this other doctor was talking about, under certain care and under certain dosage, that it could have a different effect, but everybody's brain is different. Now,
probabilities. I'm just talking probabilities. It's the same thing with
yes,
alcohol, but probabilities. Is it psilocybin?
it is very dangerous. So like what the doctor was saying is that if it needs to be under a certain environment, under a certain amount, if you introduce a different environment and this individual has a different chemistry or makeup in their brain, it could set them off where they have a hallucination, and it causes them to have violent tendencies or violent outbursts because they are not in the right state of mind. Obviously, when they see you, they do not see you, this human being that is in front of them. They see something else. Like the UFC fighter who tore the heart out of his roommate. He believed he was the devil. He really, truly believed he was the devil because this is what the state of mind that he was in while he was currently under that psychoactive drug. And THC, same thing, under certain dosages, it will cause the same psychoactive effects. So no, it's definitely not like alcohol. It's a completely different substance. When you have a drug that specifically affects the brain, and when we're not talking about a dependency, this isn't about dependency and, I'm going to become addicted to it. This isn't about that. It talks about the dangers of what it does to the human brain. And it could be one dosage, it could be one time. And you could have this very serious psychoactive effect that makes you violent. And then it's the public that suffers, is the law enforcement that has to deal with it. Again, one is too many. This is a substance that needs to be highly scrutinized and under a doctor's care for it to be really effective and help those that you want it to help, which is a small percentage. But we have to think about the entire public. We are here to serve everybody, not a small percentage. And I just like to see it to be done right for us to be responsible.
Thank you. And I think that's what our charge is here today, our charge throughout the whole entire study. Senator Nguyen.
Thank you. I apologize, Ms. Burnett. I'm not sure what your title is. I missed your introduction. Sorry, I was eating a late lunch, but thank you for giving your perspective. And I just wasn't sure, like, do you have, and I may have missed this, do you have a medical background? Because I know that we heard previously from like medical doctors, and I'm looking at all of these information that's being put into the chat with medical studies about like dependency and that kind of information. Is that what your background is in? And I'm sorry if I missed that initially.
No problem. No, I'm the lieutenant over Metro Narcotics with LVPD. I've been with the department for almost 24 years and am a drug expert, and I teach a lot on this, but I have a lot of on-hand experience with people under the influence.
So like, obviously we've heard some competing information. And so I just wanted to clarify that because I realize that these are some horrific incidences that, you're describing and that we've all seen on the news that have been, unfortunately have led to terrible like outcomes for the victims that were involved in this. But I'm curious, like in all those, and, granted, I have come from a 21-year background in criminal defense work, but I also did prosecution work as well at the beginning of my career. So were there other factors involved in some of these things, or were they strictly, and same thing with the drug arrest. And I've been trying to get that data from Metro for about 18 months now on whether or not there were like combinations. Even Mr. Garber had mentioned something about like these festivals and also the proliferation of like fentanyl and other things. So like, are these in a vacuum where it's just mushrooms, or are we talking about someone who's schizophrenic and using mushrooms, and someone who is drunk and uses mushrooms, or someone who has been on steroids and uses mushrooms? Like, where do you know any more of those details? Because I know, being on both sides of the aisle in that law enforcement and criminal defense world, that there's usually a combination of those kind of things. And do you have that kind of data, I guess, aggregated within at least Metro or within the various law enforcement agencies on how that's like determined?
That particularly, no, I do not. And a lot of times, oftentimes when you go on these calls, the information is only as good as what the individual is willing to provide. So oftentimes we do come across poly drug users. That is true. And why is that? Because each drug has an effect, and they take another drug to counter that effects of that drug, and another drug to counter that drug effect. So that's what we end up coming to. My whole point in it is that obviously we have had horrific events, and whether or not there were other factors in play, and there usually are, is that it still does a significant effect on the brain. I'm sure we are all in agreement with that. It's a Schedule I controlled substance for a definite reason. What I'm saying is that it should be highly scrutinized and under a doctor's care, 100%. And I don't think anybody here would really disagree with that. I mean, we talked about the environment. It should be washed, microdosing, macrodosing, a certain amount. This person who has this condition or that condition and what their underlying mental health condition is. Again, I think we all agree that a person, and we'd also talked about ketamine, that a person just shouldn't be using it willy-nilly. And that's what the abuse that I'm talking about is. We're talking about the abuse in that they'll take whatever dosage that they feel fit, or till they receive the desired effect that they want to achieve, whether it's euphoria or whatever it is. Having it under a doctor's care, because we're using it as medicine, I think is crucial. And thereby saying, let's do the responsible thing and have it rescheduled. If it really truly is medicine, we have the data to back that up.
Thank you.
And thank you. And I apologize that I missed the introduction. Thank you for being here.
No, thank you.
Josh Garber.
Lieutenant, thank you for being here again. Just a quick question. In your history with the legalization of some of our drugs that we've legalized, have we seen a better effect in the Valley as far as abuse, or making the illicit market worse by legalizing some of the narcotics that are out there, even the Schedule I marijuana?
Well, thank you for the question. We have seen some of our fears from legalizing the other Schedule I drug. Our fears did come true. The black market is completely out of control. We have more young people that are abusing marijuana than we ever did before in the past, which has a significant impact to one's mental health and one's brain function as a young person. We also have more people who are being murdered over marijuana than we ever have before. We have a lot of young people killing each other because they're out selling marijuana, unfortunately getting it, and they're killing each other over it. So it's our worst fears did come true when we thought that it could be legalized and when it was. And this is a never-ending battle for us that we're continuing to fight, and it's becoming tougher every day. So we have seen a lot of deleterious effects from the legalization, but it's here, and we continue to fight it.
Thank you very much.
Terry Kearns.
Lieutenant Burnett, thank you for your presentation. I appreciate it. My question, and you may not have this data available, it kind of goes along with Josh's question in terms of, we've seen illicitly manufactured drugs versus pharmaceutical grade drugs. And I know that, with the opioid epidemic, we started to see a proliferation of the illegal distribution of pharmaceutical grade drugs. So is there any data on what you're seeing? It's probably more so for the ketamine than the other two, but on what is illegally manufactured versus pharmaceutical grade, and kind of getting into that whole diversion question. Thank you.
Thank you for your question. So we have seen an increase in abuse in ketamine. Just recently, we just had a report of an individual coming off an airplane. They originally thought it was cocaine that they were snorting, but it turned out that it was ketamine. So they were snorting powder ketamine. So it's become more of an illicit street drug at this point. But when in terms of opiates and diversion with that, obviously everybody's seeing it across the country. We are in a serious issue with fentanyl, and we are seeing fake M30 pills or fake oxycodone pills, which is nothing but pure fentanyl. So we are having a serious problem with overdoses. I supervise our overdose response team, which we do have. We have done a record number of submittals for murder charges for individuals who have sold fatal doses of amphetamine to individuals here in Clark County, and they ended up dying, unfortunately. The only reason why we do not have more fentanyl deaths is because of Narcan. We do have, but we are seeing a huge increase in the use of Narcan, obviously, through our first responders as well as medical staff. But if we didn't have Narcan, we would be overwhelmed with the amount of overdose deaths that we would have with the opiates. So it is true, that part of it, because receiving, due to legislation and the help with making it harder to obtain true legal prescription medication illegally, unlawfully, it's become harder and harder. So thereby, we do see more of the fake pills that are coming out, the M30s, which of course we see coming in through the southern border mostly.
Thank you. Jonathan Dalton.
Thank you for your time, officer. A few questions, and I'll ask them straight out here, and then we can get some answers. You described some graphic, violent scenarios about psychedelics and homicides, which is pretty, startling to all of us. It's important to understand the numbers rather than the graphic examples. What data do you have to support the numbers of people annually engaging in violence regarding psychedelics? For example, there are over 350 blunt force trauma a year homicides with hammers, and there's over 140,000 alcohol-related deaths. It would be important to understand how those numbers would be relative to psychedelics specifically. Other question, you stated that you believe that psychedelics have the potential of high potential of abuse. What data do you have to support your statement that it has high potential for abuse? Because I understand that data to be precisely the opposite. You also mentioned that you found 164 pounds of psilocybin. Is that wet weight or dry weight psilocybin? Because psilocybin is 95% water when it's wet weight. So if that was dry weight, it'd probably be like, 10 pounds. And then the last thing, are you aware that the proper use of psychedelic therapy can actually eradicate opioid addiction when used properly with therapy? That's my questions.
Okay, yeah, you have a lot of questions, so hopefully I can remember all of them.
Sorry about that.
So when you ask for data, so unfortunately, no, I don't have the data to show exactly how many people have committed homicides while they were under the influence of psychedelics. And sometimes that number obviously can be skewed because people, unfortunately, are not always forthcoming. And then here in Clark County, we don't always test an individual on what type of substance that they're on after they commit a homicide. The reason being is because we don't want them to be able to use that as a defense. So there are often times where they are not tested. It's either maybe sometimes from the statements of individuals who are with that person, or they might make utterances of exactly what they took. Again, when I talk about these instances, they were ones that we definitely knew that this is what they consumed and where they were not in the right state of mind. Again, to me, one is too many. When you talk about the weight, no, I don't have it broken down whether or not it was wet or dry, because obviously these are coming in. We do get a lot of dry. And when we talk about wet, that's when we get a lab, and we have seen an increase in our labs, and we'll go ahead and we'll take all that. But the majority of it, I would say, is dry, not wet. When you're talking about abuse, the reason why I say abuse is when I don't know if your term of abuse is different from my term of abuse, is using it recreationally to me is abuse. Using it when you don't have a condition or you're not using it for medicine, again, that's abuse. Now, again, it's not deemed as medicine. And we were talking about abuse. What record do I have? Well, it is a Schedule I controlled substance. So it's been around for quite some time. Obviously, the federal government, being the DEA, has done their research and their homework to make it a Schedule I, meaning that it has no medicinal value, has a high potential for abuse and addiction. At least that, of course, that is from the data that has already been provided from decades and decades ago. So I don't have that from here, nor do I think that that's something we have to produce at this time since it's already been done. However, when I talk about abuse, is because that's what we are currently seeing, is that we have right now, it's a Schedule I, it is illegal to possess, it's illegal to consume, but we are getting it more and more. So almost 165 pounds just in 6 months, we can see that people are abusing it. We have more and more young people that are purchasing it. We have marijuana pop-up dispensaries that are popping up all the time. What we find there is a large amount of marijuana along with psychedelics being shrooms. That is popping up all over the place. And if you heard Detective Garber talk about at Electric Daisy Carnival, it was one of our most seized drugs that we did get. So when we talk about abuse, I'm talking about people who are consuming this narcotic for recreational use and illicit street drugs. And that's what they're doing. In terms of whether or not it would help with lowering the opiate crisis that we do have, that I don't know. And I don't know if anybody would really have the documentation to show that would definitely be true, because opiate is a completely different substance than psychedelic, and it has a serious euphoria effect. It is one of the worst addictions you can ever have. And your body becomes instantly, starts developing a dependency to that. It's a completely separate drug. So once a person starts to develop that, I don't know if psilocybin is something that can get them off of it or prevent somebody from ever using it. Again, I don't know if there's been enough studies medicinally for that. But everybody here keeps talking about that it should be under a care. That's all I'm saying. I'm not saying it doesn't help anybody or it's never been proven to help anybody. I'm definitely not saying that, and I would never say that. All I'm saying is that I think we can all agree that it should be highly scrutinized and definitely watched. And in my opinion, that should be under professional with a license.
Thank you, Detective. I appreciate that. And for the record, I agree in terms of we talk here about illegality and the dangers of full legality. And I think that most all of us here agree that both of those are things we certainly want to stay away from. That under the presence of a qualified medical professional is, I think, what we're looking at here, not full legality. So that's all I have. Thank you so much. I appreciate it.
Thank you so much.
Kate?
Yes, thank you. I really appreciate hearing your perspective. I'm curious to know if we have any data for Nevada on this, and this is related to Jonathan's question, on alcohol-related deaths and or legal prescription-related deaths. Do you happen to know?
So that I don't know, but I mean, I hear alcohol getting brought up often. We talk about alcohol-related deaths. Unless I would say the individual is driving under the influence of alcohol, I don't know how these deaths have associated with killing somebody else. I mean, unless, of course, like you guys talk about somebody becoming angry, highly intoxicated, and becoming very angry. The times where we see somebody under the influence of alcohol and committing a homicide, let's say, usually it's in a domestic violence scenario. Obviously, that is intense emotions that are involved. And usually that's where we see a homicide associated with alcohol. I would tell you, though, since legalization of certain drugs, we have seen that usually it's a mixture of marijuana and alcohol that are combined when we see an attack or an aggression take place in which a homicide does take place while they're under the influence. But when it comes to just alcohol and them just dying, usually that's just a medical call, and so police aren't usually involved in those.
Thank you.
Thank you.
Lieutenant Goldstein.
Yeah, last question. I'm going to make an assumption that in your position that you're doing a lot of the reading of actual research that's out there. And are you familiar with research that was published in, I believe it's the Journal of Psychopharmacology, that reflects that people who use psilocybin have a 40% reduced rate of opioid use? That there's also a even stronger beneficial effect. There was a large study done in Canada, but the US journal had a peer-reviewed and controlled study of 44,000 Americans. That's not an insubstantial study. There's also other research out there on the use of psychedelics in controlling recidivism as a measure of public safety. So I'm happy to send you a number of these, because I think public safety purview, there's many different ways to create communities that are both healthy and safe. And it's not just on law enforcement, it's on all sorts of different things.
I agree.
So are you familiar with any of those studies?
No, I'm not familiar with those studies, but it sounds like that's really great. I would have a lot of questions in regards to that, just like, were they ever exposed to opiates? Were they already addicted to opiates? Are these an alternative to an opiate as far as pain management? Is that what part of that study is? I don't know. But I'm not disputing, again, I'm not disputing that if you guys are saying that there's data to show that there is medicinal benefits to psilocybin, I'm certainly not the entity to have that debate with. That would be the DEA, in my opinion, or the federal government for a rescheduling to take place. All I'm here to talk about is what we have seen out in the field, what your typical layman citizen does not get to see on a daily basis. And when we talk about introducing another Schedule I controlled substance, have we looked at other alternatives first, like the current psychoactive hallucinogen that we already scheduled, or that we've already legalized, as well as allowing pharmaceutical companies to recreate a synthetic form of psilocybin? Have we even looked into that and making it a prescribed medication instead of just going straight to, let's just introduce a Schedule I?
Thank you. I appreciate it. I'm happy to send the research.
Thank you.
Thank you. I'm going to close off discussion on this. Kim, if you want to email your question or put it in the chat, we can get it addressed that way. There were also some additional comments put in the chat from some members. One of them related to the criminal history repository and what data it collects, and I'll see if I can look into that. You know, and all of these resources that you all are posting, I will make available in the final report from the committee. Again, we are, you know, it's not our charge to go forward and do anything other than gather information that allows people to make informed decisions if that point ever comes. So thank you, Lieutenant Burnett. I appreciate your time today, and we will move on. We will move on to, so if it had announced earlier in the meeting that we are going to have to reschedule the presentation from the Oregon Psilocybin Services as a result of the meeting date change. They were no longer available. So we will reschedule that for the next meeting, or hopefully whenever we can get it scheduled. So now I would like to move forward to the discussion of the work plan. So this is really what is guiding the work of this group, and it is based on Senate Bill 242. So if you recall, at the first meeting, I believe we went through all of these items. We did an overview of the bill. We had data presented on addiction, treatment-resistant depression. You can see all of that. The discussion of suicide prevention, mental health needs in Nevada. And I honestly am not certain if we completed or if members are comfortable with the overview of current treatment options for mental health, addiction, and post-traumatic stress disorder, whether that's something that we still want to do. I think we did do the science of psychedelics overview. This meeting, we had some stakeholder briefings from the law enforcement community. Now, we didn't get the Psychiatric Association itself, as you all know. Dr. Jane is a psychiatrist, a member, but she was not representing the Psychiatric Association. I'm not certain that the Psychiatric Association, I will follow up, but if we do want them to come forward at some future time and do something, I would be interested from members about what you would like to hear from them. And we also did not get anything from tribal communities. And these, again, are coming from the legislation and kind of the direction that it was moving us in. We will save the Oregon framework for a future meeting. I was not able to get anyone from the Colorado Rulemaking Working Group, and I'm going to continue to try. So that is also something that would have to go at a future meeting. And then we did kind of an overview of the ketamine insurance model. So we also have an obligation to hear from patient advocates, including veterans, first responders, and patients' rights advocates, the American Civil Liberties Union, potentially a Nevada Coalition for Psychedelic Medicines, and then again, an overview of current research on psychedelic substances, which, again, based on the first meeting, I am looking to all of you to kind of guide where we want to go out into the future. And I want to wrap us up by September. Summer months are very hard, so I don't anticipate us having another meeting until August. And then, hopefully being able to wrap it up in September. But when we get to the meeting dates, I do also have some October dates that I've proposed there as well. So I will just open it up to the floor. Your thoughts on what we've proposed and how to move forward. So, Kate.
Hello, thank you. Yes, in regard to learning what we can from other states, as we know, Colorado is still in the process of rolling out their legislation. So to my knowledge, we don't have any statewide data, but we do have access to the Denver report. As I'm sure you're all aware, Denver was the first city to decriminalize psilocybin, the personal possession, cultivation, and storage. And as part of that voter initiative, this was in 2019, they were required to set up a psilocybin mushroom policy review panel, which assessed and reviewed the impact of the initiative as it pertains to the public safety, the public administration, public health, and the fiscal impacts on the city and county of Denver. And I think it would be incredibly valuable to be briefed fully on the report. They said that there were no major increases in arrests related to distribution of psilocybin and no major cartel elements or organized crime, no increase in hospitalizations. We have the fortune of having one of the named co-authors on the report living here in Reno. Brian Lang is the CEO of Trans World Health Services. He's also a global consultant on psychedelics. He's the architect of a multi-responder training course for Chapter 5 of the Denver report for law enforcement and other first responders. And he would be uniquely qualified to offer some insight as far as what Nevada is trying to do versus Colorado. So I would like to formally request that we petition him to give us a 20-minute briefing on the next call if he's available, or a future call if possible.
Okay, thank you. I can get that arranged, or I will try to get that arranged. Lieutenant Goldstein.
To Kate's point, I was going to raise up, I was just in Colorado presenting at the Aspen Psychedelic Symposium, and Denver Police Department and their first responders have initiated training that has gone incredibly well in Denver. from a public safety perspective, and in being on the panel with the deputy chief, he basically emphasized that their response is to triage and to hand over anyone who may be having some type of break over to medical providers, and the training is going incredibly well, and it's countywide right now. So maybe getting a briefing from Deputy Chief Montoya from Denver Police Department could also be a good addition to Rhinelander.
Great, thank you. Josh?
Thank you very much. Also on the aspect of Colorado, I would like to reach out to the Colorado Narcotics Officers Association and see if a representative from their association, which represents all the narcotics detectives in the entire state, if they have seen what they've seen from the beginning of the legalization of any of the psychedelic drugs to where they're at right now. If the board is okay with me trying to reach out and get them to talk to the board here and see what they're getting from the ground level there.
Yeah, I'm happy to coordinate that with you. So
perfect. Thank you.
In touch about that.
Okay.
So not seeing any other raised hands. Are there any concerns about kind of what's been laid out in the work plan? Okay, not hearing anything, then we'll go with that in addition to these other topics. Whoops, I stop sharing too soon. Then the next one I have is trying to find our dates. Hold on. Okay, so potential future meeting dates, and I did email that out to you all. And I don't know if you're prepared or not to kind of settle on a date, or if you just want to give me, you know, the polls seem to be working, but I think right now, given what we talked about today, we're looking at a meeting in August, September, and October. So again, if you just want to, I'll just send out a poll looking at these potential dates. It seems to be working unless somebody else wants me to do it differently.
I think that's fine. Do you want us to give answers now, or are we able to take a look at that and get back to you?
You just take a look at it, get back to me, or again, I'll send out a poll, you know, document, and you can indicate your availability. I would say on all of those months at this point. Thank you, Senator. Okay, I think that concludes the presentations that we have today. So this is our next opportunity for public comment. To provide public comment telephonically, dial 1. Actually, before we go to public comment, John, did you want to do an introduction of yourself, since you, I believe, are the newest member, and anybody else who hasn't had an opportunity to introduce themselves as members of the committee?
Sure. Hello, everybody. Good afternoon. My name is John Oseguera. I am the Native American representative on the for the group. Unfortunately, I wasn't appointed till a little bit later, but I have been following what you've been doing because it's a subject that's interesting to me. I served in the legislature for 12 years, was the majority leader for 4 and the speaker for my last 2. And currently, for the last 10 years, I've been running a government affairs firm named Strategies 360, and we're in 13 Western states. That's me. And I will tell you also, just as we're talking about the law enforcement side of things too, I did serve 25 years on the fire department, serving in every rank to the assistant chief level, retiring from the fire department after 25 years.
Thank you. And Dr. Shad?
Yeah, hello everybody. Very useful discussion. So I am the newest, I think one of the newest members of the working group, and I'm a psychiatrist. I also run a residency program in Las Vegas. I'm a program director for the VHS Psychiatry, and I have done some research on psilocybin. I published a review paper on the neurobiological findings from psilocybin. So that is one of the reasons why probably I was selected for this committee. If the committee allows, I can send my paper so people can also read it, because it has a lot of fMRI imaging studies finding, which are fascinating. So, so basically, I just wanted to introduce myself.
Oh. Okay, there we go. For some reason, it wasn't letting me unmute myself.
Okay.
Okay, thank you, Dr. Shad. And yeah, if you want to go ahead and email me that report, I'll make sure that we get it available to everybody. And again, all the documents that we receive will be available for our last in the report that is published on behalf of the committee. Okay, so we'll now move to public comment. To provide public comment telephonically, dial 1-775-321-6111. When prompted to provide the conference ID, enter 407-099-411#. If providing public comment during the Teams meeting, unmute your microphone prior to speaking. Persons making comment will be asked to begin by stating their name for the record and to spell their last name. Is there anyone wishing to make public comments? Leah?
Thank you, Marla, and hello, committee. Good afternoon. My name is Leah Case. I'm with Bells and Case Government Affairs, and we represent the Nevada Psychiatric Association. I did put in the chat, and I thank you for bringing up that the Nevada Psychiatric Association has not yet presented at this group. The Nevada Psychiatric Association shares the view of the American Psychiatric Association. That position paper is linked in the chat here. But basically, there is currently inadequate scientific evidence for endorsing the use of psychedelics to treat any psychiatric disorder, except within the context of approved investigational studies. And it goes on from there. So I appreciate that this group would like to involve NPA in future discussions. I think you saw earlier, I counted at least 6 psychiatrists on this call today. So this is a very interesting and engaging topic for psychiatry. But a presentation from the NPA would reiterate the information from the APA, and you may be better off with individual psychiatrists like Dr. Jane sharing her information. I saw Dr. Dixon on the call, Dr. Shad is a member, Dr. Rist was here earlier, Dr. Cole was here. So there are many psychiatrists who would offer their opinions from the association perspective. However, we would follow American Psychiatric Association position guidance. Thank you.
Thank you so much, Leah. Is anybody else wishing to make public comment at this time? Hearing anything or seeing anything? Then thank you everybody for your time today and for your flexibility, and hopefully it's not as chaotic the next time. And we are adjourned.